I'm Jonathan Strober. I am a child neuromuscular specialist and professor in pediatrics and neurology at University of California, San Francisco, Benioff Children's Hospital. I've been here 25 years, taking care of kids with all different sorts of pediatric neuromuscular conditions, and especially myasthenia gravis, where we see our patients in clinic. And I actually started the Pediatric Myasthenia Gravis Consortium about 6 years ago with 6 centers from around the country trying to work together to improve the care of kids with pediatric myasthenia gravis. So for pediatric myasthenia gravis, I think in some ways we're similar to adult treatments, with the mainstay of treatment being mestinon or pidostigmine, which is a short-acting medication that helps kind of alleviate some of the symptoms that patients have, but it's not a long-term solution. So because it's an autoimmune disorder, the body making antibodies against part of the junction between the nerve and muscle, we often try and either get rid of the antibodies, or we help kind of reduce the injury that's occurring to the body because of the antibodies and the immune reaction. And so steroids is a first line for many of our patients just to get things started. But especially in pediatrics, it's really bad for your body to be on long-term steroids. And so we try and find something that would get the kids off of the steroids. And the older treatments, things like azathioprine or cyclosporin, they're kind of big hitters and stuff that's been used for a long time, chemotherapy and transplant patients. So we've been able to, over time, have newer therapies that are kind of more focused. Things like rituximab, which help get rid of the cells that make the antibodies. And then the newer therapies became available. But right now, the only one that's actually approved for use in pediatric myasthenia, so 12 to 16 or 12 to 18-year-olds, is Nipocalimab, which works by dropping your antibody level down. It prevents the antibodies from getting recycled. And so you basically drop your level of antibodies to help reduce the injury that's occurring. Some of the other medications that are out there, like eculizumab, or now the new one, ravulizumab, or even the other antibody level dropper, as I'll call them, these FcRn-inhibitors, none of them actually have approval at this point for pediatric use. And so a lot of times, even if we want to try it, we get pushback from insurance companies because it doesn't have the FDA approval. So Nipocalimab works by blocking part of the system of antibody regeneration. Because if you can imagine, since many people know that there's lots of different immunizations that are out there, right? So your body can only make a certain amount of antibodies at a time and hold on to them and have them in your blood. Otherwise, we would have too much protein in our blood. So we have to recycle the antibodies we have so we can make new antibodies over time. And so the antibodies get taken up by the cell and often get recycled back out. But there is a process in which they can actually be broken down. And so Nipocalimab helps by increasing that process of having the antibodies broken down so that your antibody level in general drops. So the phase 3 trial, which took place in adults, but we also did a pediatric arm. So we were able to enroll patients that were 12 to 18 to show that we were reducing antibodies in the pediatric age group as well as in the adult group. And it also showed that there was benefit to the patients, better functional scales, that their quality of life was better. Their scores were all doing better when they were getting treated versus the placebo group. I think with the approval, especially in the pediatric age group, it'll be much easier to get these medications to our patients who really need them because we won't have to hopefully fight as much with the insurance companies. There's always a fight with insurance companies in these conditions that they don't truly understand. A lot of the older drugs that we had to fight for 10 years ago that are now, say, generic, the insurance companies might come back, oh, have you tried this one? Have you tried this old one before you try the new one? And it's like, but that one's not even approved. And you fought me 10 years ago to get it approved because you said it wasn't approved. So I want to use the one that's approved and the one that I think is relatively safe. That's the nice thing. These are much safer than the older medications and better and more focused. And so the risks to the patients are less. And especially when we're dealing with our adolescents, it's just a very difficult group to work with. And so I think being able to get these drugs approved for the patients that really need them, it's going to be really helpful in treating the patients. I think that what's been so important, apart from getting this new drug approved for the adolescents that we take care of, is that the pediatric myasthenia, it's great that pediatric myasthenia gravis is actually becoming more and more recognized. And a lot of times, a lot of the pediatric parts of these conditions are overlooked because it's not as common as in the adults, or it's harder to diagnose. And so some kids go undiagnosed for a long time and they don't get the treatment they need to do well. But now we're having much more presence in the community, in myasthenia gravis community. And so these kids are able to get to providers who can actually help them in a better way.